Good morning, everyone. It's really my pleasure to be asked to do this presentation this morning. It's amazing that I can sit here in New York and do this presentation to you all over the world, and I'm really honored to be asked. So the title of my talk is Pediatric Chronic Rhinosinusitis, What I Didn't Know and What I've Learned. And the reason why I titled it that is because by training, I'm an adult rhinologist. I did my fellowship training at Northwestern in Chicago quite a few years ago, and I've really come to have an interest in pediatric rhinosinusitis as due to the fact that I was getting a significant amount of referrals of kids with chronic sinus issues, and I sort of had, I felt like a basic understanding of what, I had an advanced understanding of what adult chronic rhinosinusitis was, but in terms of children, I was trying to apply those sort of principles to children, and I felt that I was wanting for more information because things just didn't seem the same. So that was kind of where things started for me. In terms of disclosures, I have no disclosures. So to start with, I asked the question, is pediatric chronic rhinosinusitis the same disease as adult chronic rhinosinusitis? And so to answer that, I'm going to take a look back at a few of the cases that I have dealt with that really made me sort of question or try to understand the difference between adults and children. So here you can see this is a 15-year-old young patient with a history of chronic sinusitis with nasal polyps. And she was first seen at the age of 8, and her phenotype is nasal polyps. She has no cystic fibrosis mutation. She had multiple revision polyp debridements. She failed steroids and antibiotic rinses, and she's chronically colonized with Pseudomonas. At home, she requires supplemental oxygen. And of note, what's important about this patient, she has an underlying diagnosis of fucosidosis. So what is fucosidosis? So fucosidosis is a lysosomal storage disorder. It has a deficiency of the alpha L fucosidase. It's an autosomal recessive inheritable disorder. And it essentially causes pervasive global developmental delay. They get abnormal bone development, seizures, abnormal muscle stiffness, angiokeratomas, visceromegaly, and recurrent respiratory infections. Now, CRS has not been part of the disease milieu of fucosidosis, at least reported in the past. And that may be because, and I conjecture that that's because the children with fucosidosis haven't in the past really lived that long. There are two types of fucosidosis. One is a quickly fatal type, and the second type is a more indolent type that really usually has death by the 3rd decade of life. Now, this patient's in her 2nd decade of life. What you can see in the images here in figure 1 is a CAT scan of the patient upon presentation to me. Now, granted, when I had seen her, she'd already had one left-sided endoscopic sinus surgery. And so what you see here is she does have pretty fulminant nasal polyposis, or a pacification of the left ethmoids, nasal cavity, and maxillary. But you can see there's some inflammatory disease occurring on the right side, but not really that significantly. And what I want to bring your attention to is when you look down at figure 3, this is a post-surgical scan a few months to year, maybe perhaps even a year later, where she has recurrence of the polyposis on the left. You can see that the maxillary is somewhat more aerated, but there's still certainly opacification on the high ethmoid cavity as well as the posterior ethmoids. But on the right, you can see there's been extensive polyposis formation. And so in the interval while between surgeries, this patient was getting aggressively treated with steroids and antibiotic rinses, and yet her polyp was really recalcitrant and progressive. So in sort of the typical picture of adult sinusitis, inflammatory polyps we think are an eosinophilic process. They have a thick basement membrane. They have an extracellular matrix that has scattered fibroblasts and dense connective tissue. There's a significant amount of fibrosis in polyps, and they have the typical ciliated columnar epithelium is metaplastic to stratified cuboidal epithelium. And so that's, this H&E stain on this top is really a classic polyp picture. And what you see on the bottom is a picture of the patient's polyp. And her polyps are not typical in any way. What they show is a dense lymphohistocytic infiltrate and foamy macrophage infiltration. And this is consistent with a lysosomal storage disorder. So even by phenotypically, you look at this patient and she has polyps, but on the cellular level, they're not the same as inflammatory polyps that we're used to dealing with. And that, in my opinion, is why I can't get proper control with typical medical therapy for this patient. So the impact of pediatric chronic rhinosinusitis is pretty significant here in the US. There's 5.6 million annual ambulatory care visits for CRS and greater than 1.8 billion in healthcare costs. We know that just like in adults, CRS in kids causes a decreased quality of life. They have an increased missed school days, increased susceptibility to orbital and intracranial complications, so an acute on chronic situation, and an exacerbation of asthma. And what you see here in this panel, or in this CT scan, is a patient who has evidence of chronic underlying inflammatory disease with an acute infection causing a subperiosteal abscess here in the orbit. So this would be a complicated acute sinusitis. So how do you classify pediatric CRS? Well, there are two key papers that were published in this decade: the European position paper on rhinosinusitis and nasal polyps, the EPOS paper from 2012, and the clinical consensus statement on PCRS in 2014. That's from the US. So essentially they agree in that you need 2 or more of the symptoms of nasal blockage, obstruction, congestion, nasal discharge, plus or minus facial pain or pressure and cough. And you still need to have the endoscopic evidence of disease or CT evidence of that disease. Adult CRS is similar, but a little bit different. So with adults, we know that you need 2 or more of the symptoms of nasal blockage, obstruction, congestion, nasal discharge, and facial pain and pressure. And you also need this endoscopic evidence of disease or the CT evidence of disease. But the difference is this cough. So in kids, it seems like cough is a much more positive predictor of CRS than it is in adults. And we're going to talk about that in the next few slides. So how do you classify a child with CRS based on their CT scan? So if you scan, all kids, 18 to 45% of normal kids are going to have some sort of finding on a CT scan. So obviously not all those kids have CRS. So the non-symptomatic average Lund-Mackay score has been calculated around 2.8. And then PCRS is essentially a Lund-Mackay score greater than 5 to be considered significant. And most common symptoms in this particular study was cough, rhinorrhea, nasal congestion, and post-nasal drip. So again, facial pressure, kids are not necessarily complaining about that in the same way that adults are. In this last study, 66% of children with chronic cough had abnormal CAT scan findings. So again, chronic cough is a big indicator that there could be some sort of paranasal sinus inflammation. So what's the prevalence of CRS in kids? It's unclear because there are very few studies on kids with CRS in general. So to estimate the prevalence has been pretty difficult. In this particular allergy practice, they had 91 patients with CRS symptoms for greater than 3 months. And so those patients got a CAT scan, and 63% of those patients had CT evidence of CRS. And so again, the most predictive symptoms of CRS were cough and then rhinorrhea. But the most negative predictor was sneezing. And I always think that's important to think about because sneezing is, just like in adults, sneezing is really an allergic symptom. And though, you certainly can have CRS patients who have allergy, allergy on its own is not a main driver of CRS, which many of you all know, I'm sure. And so sneezing as a symptom, if the child is sneezing all the time, for me, it doesn't push me towards a CRS diagnosis to start. So quality of life in children with CRS is hard. It's hard to do quality of life studies on children because it's hard to get reporting from them. that can be validated, and oftentimes the parents are influencing the quality of life measurements, and obviously parents can perceive the quality of life of their child in a different way than the child themselves are perceiving it, correct? So the quality of life studies that do exist have shown that pediatric CRS has a worse quality as compared to asthma, ADHD, juvenile rheumatoid arthritis, and epilepsy. And that's actually pretty similar to the adult quality of life studies, which show that adult CRS has a poorer quality of life in patients with severe cardiac disease, which you think would be not the case. But in kids, the validated quality of life measurement is the Sinus and Nasal Quality of Life Survey, which is the SN5. The SN5 has 5 domains, which all concern sinus infections. The first is sinus infection, nasal obstruction, allergy symptoms, and then emotional distress, and ultimately activity limitations. And so the SN5 is felt to reflect the previous 4 weeks of illness. And so also it's shown to correlate positively with CT scan scores in patients with CRS. So it may be of a, if you're trying to figure out if this kid is worsening or improving, or what perhaps might be going on in their sinuses, you could perhaps use serial SN5s rather than repeating CAT scans. Obviously, we all want to reduce the amount of radiation children get, so I really try to limit the CAT scans to kids I think we're actually going to need a surgery on, or have some sort of clinical question that I can't answer based on the physical exam. But you can use this SN5 if the kid is old enough to understand how to take the study as a way to sort of, judge their progress. And then there's limited evidence showing that endoscopic sinus surgery has an improvement in quality of life. And we're going to talk about that in a little bit. So here's another child that I've been treating. So he's a 12-year-old with CRS with nasal polyps, and he has a kidney transplant, and he's chronically immunosuppressed on tacrolimus and hydrocortisone. And he also has failed medical therapy. He underwent endoscopic sinus surgery and adenoidectomy in 2017, and he had a quick regrowth of his nasal polyps. And he underwent revision endoscopic sinus surgery again in 2018, and he's been maintained on a gentamicin, budesonide, and shampoo rinse. He has no cystic fibrosis mutation. So again, a patient with polyps with no CF. But what he does have is a diagnosis of Algrove syndrome, which is an adrenal insufficiency, and which causes multiple issues, including his need for this kidney transplant. He's chronically colonized with Streptococcus intermedius. And so what you can see him up in the top picture, he's a nice young guy. And in the lower picture, what you see is his CAT scan, and his CAT scan looks frankly terrible. He's got pan sinus opacification. All the maxillary ethmoids here and the base of the frontals appear affected. But I think what's also interesting is you can see he has some widening of the nasal vault. And you see that on his anterior view right here. I don't know if you can see my cursor, but I'm pointing to his nose, that the dorsum of his nose is somewhat widened. And you can see that also on the CT scan. And now, due to the Algrove syndrome, there are some facial dysmorphism. It could be part of that. So I can't blame necessarily this chronic polyposis on widening his nasal vault, but I think it could be contributing to it, as we've seen in, certainly seen in adults with chronic nasal polyps. Okay, so moving on. So what is the microbiology in children? Does it differ, or is it the same as adults? And so I would say it's the same and different. So the most common bacteria that are found in kids reportedly is alpha hemolytic strep, Streptococcus pneumonia, Haemophilus influenza, coagulase negative staph, Staph aureus, and anaerobes being uncommon. Anaerobes are uncommon. And in adults we would include Moraxella. Hold on 1 second. I lost it. So in any case, that leads us to biofilms. So biofilms are the complex aggregation of bacteria with protective adhesive matrix. So what role do biofilms play in pediatric CRS? Well, we know that biofilms confer a resistance, antibiotic resistance to bacteria, also an immunologic resistance for the bacteria. By forming this sort of matrix, in some biofilms are actually able to take on properties that they didn't have or emit proteins that they aren't able to do on their own. It's thought that perhaps the shedding of this planktonic bacteria from the biofilm actually starts to colonize other surfaces. So for instance, if the biofilm is in the adenoid bed, it could be a chronic reservoir of infection where it flakes off and starts seeding the nose and ultimately the paranasal sinuses. And when you looked at a mixed adult pediatric population, over 80% of those people had some sort of biofilm formation in their nose or paranasal sinuses. Now, adenoids. Adenoid is a really important thing to talk about when you're talking about pediatric CRS. Adenoidectomy alone has been shown to be effective in resolving CRS. So in patients who had adenoid hypertrophy and chronic rhinosinusitis, 88 to 99% of those patients were found to have a biofilm on their adenoids. Whereas they compared that to patients who just had adenoid hypertrophy and were having, adenoidectomy for obstructive sleep apnea or some other reason, and only up to 6.5% of those kids had a biofilm. So clearly the kids with CRS are having a biofilm, a significant biofilm presence. And so again, it brings us to this question, is adenoiditis causing the discharge? And here on in the electron micrograph, you can see essentially what a biofilm on the adenoids looks like. It's also thought that perhaps chronic adenoiditis could blunt the immune response of the nasopharynx. So in this particular study, they looked at patients with adenoid hypertrophy and chronic rhinosinusitis, and they found that ultimately those patients with the CRS had lower expressions of immunoglobulin A, surface immunoglobulin, which we know is important as your first line immunity. All other immunoglobulin expression was within normal limits. And so again, bringing the question, are patients who are having chronic adenoiditis unable to mount a local immune response that will ultimately help them prevent this biofilm formation? Other studies have shown that adenoids of CRS patients have higher cytokines, TGF-beta1, MMP2, and MMP9 have been elevated, and the tissue inhibitor of metalloproteinase 1. So clearly, as we know, a chronic inflammatory state can elevate inflammatory markers, but it is seen here in adenoids, and it's specific to the adenoids of patients who have CRS as compared to the patients who have adenoids who have or adenoid hypertrophy who don't have CRS. Anatomic factors, I think you always have to consider. Is there an anatomic reason or potentiator for the child's sinus complaints? Concha bullosa is not uncommon in kids. Pneumatized superior concha is also possible, Haller cells and Agranazzi cells. What's interesting, and I think pretty understandable when you think about it, is septal deformity is not as common in kids as adults. Obviously, septal deformity is most likely occurring in most patients, through facial growth. And if your kid is somewhat young, they haven't gone through a significant growth phase. And so their septum isn't necessarily crooked, but you should always look for it. And in some rare cases, it might be potentiating the problem. So here's another case that I got early on. And so this is a 12-year-old boy with rapidly progressive onset of asthma and CRS with nasal polyps. So he responded really well to steroids, but the minute you took the steroids away, he did terribly. And so he went on to get a CAT scan due to his really progressive asthma, and it showed a CAT scan of his chest, and it showed hilar adenopathy and some ground glass appearance to the lungs. And his CAT scan of his sinus, you can see here, showed complete opacification of the paranasal sinuses. So he really had just this fulminant nasal polyposis. He underwent a nasal biopsy, which showed classic inflammatory polyp features. I did do electron microscopy for cilia, but did not see any cilia in the biopsies. I don't think that's really that uncommon in the nose with chronic inflammatory states. I think the cilia sort of are pretty brittle and in fact may actually disappear when it's chronically inflamed. So he went on to have a lung biopsy, and he did have normal cilia in the lungs. And then he had lung washings at that time, and that showed an eosinophilia with no bacteria present. And he also had a lymph node biopsy because he had a lymphadenopathy, cervical lymphadenopathy, and he showed eosinophils were abundant and no malignancy. So again, this is a pretty interesting case, and essentially what happened, we took this kid got serology, and here you can see his complete blood count and his differential. And of note, you should recognize that the eosinophil count is extremely high. And so what this kid ended up having had developed was hypereosinophilic syndrome. And so hypereosinophilic syndrome occurs, there's certain criteria, obviously, you have to meet to qualify for this disorder. Essentially, you have to have greater than 1,500 cells per microliter on multiple 2 examinations on an H&E stain. You do a bone marrow section and you look for the percentage of eosinophils that exceeds 20% of all the nucleated cells. Or you can have extensive tissue infiltration, or you can have marked deposition of the eosinophilic degradation products demonstrated by immunofluorescence. So essentially, you can look for dead eosinophils. The systems that are classically affected are the skin, so dermatologic rash, pulmonary cough and breathlessness, which obviously this kid had, gastrointestinal, cardiac, and neurologic. Now, adults can have hypereosinophilic syndrome too. It's definitely possible, but I think it's not as common in kids, and I bring it up as something to think about when you see these kids again with these fulminant nasal polyps. My knee jerk always was to think cystic fibrosis, but here I presented 3 kids in a row who didn't have cystic fibrosis and had really significant polyposis. So in other cellular studies in children are pretty sparse, but what has been reported is that in kids, they found there was an increase in neutrophils actually, and CD8 positive cells, macrophages, and B lymphocytes and plasma cells. And there's a decrease in the epithelial disruption and a decrease in the thickening of the basement membrane. So that's really in specific contrast to what we know about adults. We think most adult polyps specifically are eosinophilic in nature, and CD4 is a more common cell. And that's, not what they found in this particular study. And then we know that in polyps, we usually think of the basement membrane being thickened, and here you're seeing a thinning of the basement membrane. Allergic rhinitis, I think allergic rhinitis is just like in adults. Kids are as likely to be allergic as they are unlikely to be non-allergic, and that sort of pans out throughout the literature. Asthma is strongly correlated with CRS, and CRS management is likely to cause improvement in asthma symptoms. And it's also likely to cause a decrease in the amount of medications that are used. Reflux, acid reflux, this is something that has always been bantered about as a possible cause of sinonasal issues. No one has really proven that reflux has any significant impact on CRS, especially in kids. So I don't really, rush to treat kids for reflux unless they have other signs of acid reflux. I just don't see that as being a big inducer of inflammatory disorder of the sinonasal cavity. Immunodeficiency. So this is something that I took a specific interest in. In adults, there's been a few important analyses. This first one looks at specific antibody deficiency in adults with refractory chronic sinusitis. And what they found are a couple interesting things. So they found, firstly, in strep pneumavax non-responders, they had a lower overall baseline IgA. So those patients were more likely to have a specific antibody deficiency and an IgA deficiency, as opposed to the patients who are normal baseline people. What they did is they went ahead and they challenged everyone with a pneumavax and then retested them. And so in that new cohort, they had a group of non-responders, so people who got the pneumavax challenge but didn't mount a proper immune response. And so obviously, as compared to the responders, those people had less protective antibodies, but they also interestingly had a smaller increase in the titers after the booster. So they had less antibodies produced and less of them. So the total titer was lower. In this other study, which is a systematic review of patients with CRS, they found that in all CRS patients, about 13% of them had CVID, so combining variable immunodeficiency disorder, including IgG, IgA, and IgM deficiencies. Refractory CRS was 23% of them with CVID. So the people who are really not responding to any medical therapy, they should be really suspicious of having CVID. 1 in 4 could have that. 5 up and upwards of 50% had an IgG subclass deficiency, and 8 to 34% had a specific antibody deficiency. So again, that specific antibodies are your IgGs to your vaccines. So in children, there's not a lot of studies of this on this topic. There's one prospective study which showed that 34 of 61 kids showed an abnormal had an abnormality in their immune study. It doesn't necessarily mean positive or high or low. Depressed IgG3 was the most common. And so what they found also is that they talk about this poor response to the specific antibodies. So you have in the strep pneumovax titers, there should be 14. And if you're lower, if 7 of them are deficient, or 7 or greater, then you're a non-responder and you need a booster. So if you're low, you need to boost that child, retest them in 6 weeks, and look at the titers again. If the titers have now if you have a 7 to 8, greater than 7 or more that are greater than your laboratory reference, in this case 1.3, your child is a responder. But if they don't, then they're a non-responder, and that kid should certainly get a thorough immunologic evaluation. Other studies have shown IgA deficiencies, IgG2, IgG3, and then some studies have shown no abnormal response to vaccination. So the data is mixed out there. And there was one pilot study that was done a few years ago where they gave 6 immunocompromised kids IVIG over a year. And they did find that in those 6 kids, they had a decreased antibiotic intake, decreased episodes of sinusitis, and CTs showed improvement. So I go back to the European position paper on rhinosinusitis and nasal polyps. What they suggested, they made this recommendation of a child with CRS. They recommended that you get major immunoglobulin quantifications. They wanted IgG subclassing. They recommended titers to tetanus, diphtheria, pneumococcus, a CBC, B and T cell profiles, titers to Haemophilus, IgE, and IgG to Aspergillus. So I looked at this and I thought, well, that's a lot of stuff. And, where is that coming from? Because when you review the literature, there really isn't a strong basis for some of those recommendations. So what we did here at Weill Cornell is we did a 10-year retrospective review of all the kids with CRS and recurrent acute rhinosinusitis. So essentially, it ended up being a cohort of 27 children, 17 in the CRS and 10 in the recurrent acutes. Now, granted, it seems like a low number, and it is because these children were culled from the electronic medical record. But I'd argue that these cases are very pure cases. They meet all the criteria that are necessary to be included in these categories, and they're really, because we have evidence of because they meet those criteria that I said prior, we really excluded the chronic runny nose kids and things like that, diagnoses like that might complicate this data. Okay, so we looked at the immunologic testing that these children had undergone, and we looked again at complete blood count. We looked for thyroid function testing. We looked at quantitative immunoglobulins, including major classes, IgG subclasses, and the pathogen specifics, the diphtheria, Haemophilus, tetanus, and pneumococcus. And this is our data set. And what's interesting is things are kind of all over the place in these kids. But when you really look close at it, there are some consistencies, and I'm going to talk about that right now. So here's another way of looking at that data. So interestingly, 55% of the group in total had a low strep pneumococcus titer. So they had a specific antibody deficiency. 30% had low Haemophilus titers. The next biggest derangement was the high levels of IgE in 25% of our cohort. And then we also saw a small amount of elevated eosinophils, IgA deficiency, IgG deficiency, IgM, IgM could be low or high, and a low IgG1. So looking at our total immunoglobulin abnormalities, so we had an overall prevalence in our group of 50%, and that includes children with high or low values. So what you see here, though, is that IgE was our most common derangement in high. It was mostly elevated in 23.5%. And of that 23.5%, 75% of those patients had environmental allergens. So there you can see that just like in the adult population of CRS, you're likely to get a cohort of patients in there who are also allergic. In this case, about 1 in 4. Here you can see IgA and IgM, and the arrows are pointing to the low groups in 11% and 13% respectively in either group. I think what's interesting, though, is it doesn't necessarily meet significance, because you can see that in the recurrent acute and the CRS, they had elevated IgA and IgM. So it's sort of confusing what's going on there. Now, again, the left graph we looked at, so it's a protective immunoglobulin deficiencies, 55% for strep pneumo and 30% for Haemophilus. And then if you sort of break that down a little further on the right for pneumococcal, 58% of those patients who had, 58% who had CRS had a pneumococcal deficiency, and 50% of them were recurrent acutes. And then we also broke that down into the patients who underwent surgery versus no surgery, and it was about 63% and 44%. These were not statistically significant. We looked at the culture data that was available, and our most common bacteria that we found in this cohort was Haemophilus, followed by strep pneumo and Moraxella. Those are the 3 most common infectious bacteria in adults, and it's per our study, it is also the most common. So I think that Moraxella is probably playing a role here in kids as well, and is certainly should be considered. You have diphtheroids, Staph aureus, and other strep species as well. I think what's interesting, though, is we found no association between the culture results and the pathogen-specific antibody deficiencies. So if a kid had a strep pneumo deficiency, they didn't necessarily grow strep pneumo. And so that's, I thought, was kind of interesting. So in summary, for that study, we essentially said we found no abnormalities in tetanus and diphtheria. We found no abnormalities in thyroid function. We still feel that, anatomic anomalies and allergic disease are major contributors to rhinosinusitis. There's an elevated prevalence of pathogen-specific immunoglobulin deficiencies to strep pneumo specifically, but also Haemophilus. And then there's a significant rate of subclinical IgG deficiency in pediatric CRS and recurrent acute rhinosinusitis. So when we ultimately made a recommendation, I look back at that EPO study where they recommended the CBC, all these different things. We sort of called it down based on what we see, and we will sort of recommend the CBC with differential, quantitative immunoglobulins, IgG subclassing, strep pneumo, and H flu titers. But I'm going to defer on the tetanus, diphtheria, and the TFTs, because really it has not really shown to be really abnormal, number one, but number two, there's really no pathogenic causative effect on CRS, it seems, of those disorders at this point. So when you're evaluating your kids, it's sort of a little less blood, and that's what's helpful about that, a little less blood drawn. So here's another patient that I have. This is a 24-year-old female with Cartagena syndrome. So we remember Cartagena syndrome is primary ciliary dyskinesia, situs inversus, and bronchiectasis. So obviously she's had this since childhood, and she has CRS and chronic rhinitis, and she underwent a prior septoplasty and turbinate reduction and a possible polypectomy by a pediatric otolaryngologist when she was adolescent. I say possible because the operative report talks about a polyp removal. But when we look at her scan down here, you can see that at the point of that scan, she had no evidence of polyp formation. And on endoscopy, she also has no evidence of polyps. She's had multiple ear tubes, and she lives with daily congestion. and her lungs require daily chest PT, I'm able to maintain her on a budesonide nasal rinse, and that seems to make her feel improved. But I think what's interesting is that she really doesn't have polyps. She's really quite well aerated. You can see there's some mild to moderate maxillary inflammation on the right and left. But overall, pretty good sinus CT. And I include the chest x-ray because you can see that situs inversus, which I think is always interesting for us to look at. Primary ciliary dyskinesia is an autosomal dominant inheritable disorder. It has about a half of the PCD have Cartaginer syndrome, and you diagnose it with the saccharin test. So you put a little saccharin in the nose and you see how long it takes for them to taste it, and if over the normal amount of time, there could be some ciliary dysfunction. When you examine the cilia, you do that with electron light microscope, and there's two different sort of problems that can occur with PCD. They can either lack the outer dining arm, or they can lack both the outer and the inner dining arms. And interestingly, in PCD, nasal polyps is unlikely. So it's not likely for patients with PCD to even have polyps. And she fits that, right? She doesn't have any polyps. Cystic fibrosis, I'm not going to spend a lot of time on this because you could spend months on this. It's an autosomal recessive disorder, which is a mutation in the CFTR gene that's on 7q31. The CFTR gene is a cAMP-mediated chloride ion channel, and it's present mostly in the exocrine glands of the lung, the liver, pancreas, and intestines. And so by increasing, what it does is increase the viscosity of the secretions by 30 to 60 times. And so that ultimately causes a bronchiectasis, pancreatic insufficiency, CRS, nasal polyps, and Pseudomonas. Pseudomonas, I'm sorry, is the most common bacteria that's found. But interestingly about this nasal polyps, there's 70 to 50% of patients, 7 to 50% of patients who have CF have nasal polyps. But that means 50% of them don't have nasal polyps. And I think that's kind of interesting too, because I just, in my training had always thought of CF as being nasal polyps, hallmark for CF, and CF always has nasal polyps. And it's really not the case. And I'm sure people who deal with a lot of CF know that. So if you have kids who are doing poorly respiratory-wise and don't have nasal polyps, you should still consider CF. So it's because of its really high prevalence. Young syndrome. This is a recurrent sign of pulmonary disease, an obstructive azoospermia, and nasal polyposis. And so you can diagnose that. Well, one of the things that's important about Young's disease is that the sweat chloride test is normal. So obviously in CF kids, you're going to do the sweat chloride test, which will be abnormal. The ciliary function is also normal in Young syndrome. And the azoospermia comes from an excess of the inspissated secretions in the epididymis. And it's responsible for a really high degree of male infertility, up to 7.5%. So something to keep in the back of your mind. Churg-Strauss is a systemic vasculitis that you will see if you see a lot of sinus disease. It's of the small and medium-sized vessels. It's an eosinophilic process. The nasal polyps are present up to 60% of Churg-Strauss syndrome patients, and corticosteroids are highly effective in the treatment. And you need 6 primary characteristics, or you need 4 of the 6, primary characteristics to qualify to have Churg-Strauss. So it's asthma. You need to have an eosinophilia greater than 10%, neuropathies, pulmonary infiltrates, paranasal sinus abnormalities, which we're interested in, and then extravascular eosinophils. So what's the role of surgery in these patients? Well, everything you read always says you do surgery when maximal medical therapy has failed. And so what is maximal medical therapy? Well, no one has any consensus on what maximal or what appropriate medical therapy is. And so it really leaves it up to the practitioner as to determine what they think is maximal. I'm going to tell you in a few slides what the papers recommend. But essentially, when your treatment has failed, you can move on to a surgical, essentially a surgical arm. Firstly, adenoidectomy in kids that are 6 years old and under, adenoidectomy should be performed first. A really high percentage, up to 70% of the kids are going to get better with just an adenoidectomy alone, which sort of harkens back to that biofilm theory. But in children over 7, it becomes a little bit less clear. So they do a little bit, their improvement is a little more murky when they get start to age over 7. What's the role of sinus surgery or endoscopic sinus surgery? Well, there's been 2 sort of studies, both came out in 2013, and they both showed improvements in symptoms and quality of life. And I mean, I guess that's really consistent with the adult literature, but they showed that improvement to be as high as 100%. And so I'm always a little suspicious when people report 100% improvement. But that being said, it is, at least here in these particular studies, they did show some improvement in quality of life for the kids after sinus surgery. I think balloon catheter dilation is always a topic that people are interested in. In 2010, Dr. Hassan Ramadan put out this paper where he explained that balloon catheter dilation with adenoidectomy was superior to adenoidectomy alone. The mean age population of his group was 7.7. So essentially, when he did a balloon catheter dilation and an adenoidectomy, they just did better than the kids who we just did the adenoid on. He then went on in 2012, he reported that in patients who had had an adenoidectomy, when he went back and performed the balloon catheter dilation, they had 81% of them improved. So, and that mean age was 9. So those kids were a little older. So, you know, sort of maybe saying that in the older kids with CRS, the kids over 7, maybe adding the balloon catheter, and he's dilating the maxillary sinus. So adding the balloon catheter on a maxillary sinus dilation, maybe that's you know, beneficial for those kids. In 2017, Zachary Soler did a non-randomized prospective multi-institutional trial of balloon catheter dilation. And they had 50 patients, and they broke them up into children and into adolescents. And 40% only underwent a balloon catheter dilation, and 60% underwent balloon catheter dilation and another procedure. And what they showed is they had significant improvement in symptom control in both groups. And they didn't really find any difference in the symptom control between the kids who just had balloon catheter dilation and those who had balloon catheter dilation and other procedures. So, I mean, I think that's pretty interesting in that, you know, the limited surgery or limited intervention, which I consider balloon catheter dilation to be a limited procedure, could have as much of an improvement in symptom control as more extensive surgical procedures. So there are some absolute surgical indications: mucocele, obviously, silent sinus syndrome, intracranial polyp, allergic fungal rhinosinusitis, and of course acute invasive fungal sinusitis. These are surgical indications. That, you know, you're not going to sit there and try to manage them medically. You're going to intervene in them surgically. So let's summarize. So the clinical consensus statement on pediatric CRS from 2014, they made some recommendations and some no recommendations. So in reference to the medical management, they recommend a daily topical steroid, a daily topical nasal irrigation, 20 consecutive days of antibiotics, and culture-directed antibiotics. So here you can see maximal medical therapy as per this consensus statement is 20 consecutive days of antibiotics. And that really just, I think, harkens back to the adult literature that says about the same thing, 3 weeks of antibiotics. They made no recommendation about GERD management. Now in surgical, they recommended adenoidectomy for children less than 6. CT scans are indicated, so you should get a CT scan. Sinus surgery can be beneficial. Sinus surgery doesn't cause impairment in growth, and I think that's really important because that was always a concern that you were going to impair facial growth. And there's a benefit to reducing concha bullosa. And yeah, they made no recommendation about these things. So tonsillectomy without adenoidectomy is ineffective for CRS. So the long and short of it is, if your kid has CRS, you got to do the adenoid. You got to take the adenoids out. There's no reason to just take tonsils out. Tonsillectomy on its own is not going to improve a kid's CRS. The tonsils are really not participating in this process, it seems. So and if you don't address that, you have to address the adenoids. Now, if you need to address the adenoids and the tonsils need to go at the same time, absolutely. But a tonsillectomy on its own is not going to help. Post-op debridements are not essential for good outcome. And I think that's kind of important because debriding children is pretty hard in the office. So most of the time you have to book them to go back to the OR. So it's another trip for them, another general anesthesia. And inferior turbinate reductions probably don't impact CRS very significantly. So what do you do? Who actually has pediatric CRS? So, that is like such a difficult question. And the reality is it's unclear. We don't have a prevalence, and you really just have to really strictly follow these inclusion-exclusion criteria to try to get your kid, to put that kid in a box so that you can figure out, some sort of treatment algorithm for them. I always impress upon, I just examine the patients. It's mostly, I always impress upon that, to my residents. You got to look at the kid. It's really hard to examine children and doing a really good endonasal exam, but you really need to do it because you'll find things, and that, will ultimately could influence your diagnosis. Adenoidectomy, again, highly recommend. You have to consider their comorbidities. I presented all these kids who have different problems that are leading to sinonasal pathology. You have to remember that not all nasal polyps are cystic fibrosis, right? So essentially, you got to think outside the box to some degree, like what could be going on with this kid who's in front of you. You want to remember the immunologic testing for refractory patients. Sinus surgery can be helpful. Medicated nasal rinses help, I think. And remember that refractory disease is not your fault. I mean, it can be very humbling trying to treat these children because their disease is extremely indolent and difficult, and the parents are upset. But you're just doing the best you can as long as you're approaching it in a real, methodical, stepwise fashion, and just, keep working at it. So with that, I thank you very much, and I'm happy to try to answer some of the questions if I can figure out how to do that.
Thank you. Thank you very, very much for a nice lecture. You can hear me, right?
Yes, I can.
Okay, great. Thank you. So just I have a few questions myself. I mean, if you leave out these a really symptomatic group of patients who have major or significant disease, what do you think about the statement that kids have snotty noses and it always gets better with age?
I think that's wishful thinking. There are some kids who just do have snotty noses. I mean, I certainly have a handful of them, and I've examined them over and over again, and we've even gone on to get a CAT scan, and there is no sinus inflammatory disease, but the kid is just producing a ton of mucus. That is not sinusitis. If you don't have evidence of chronic inflammatory disease in the sinuses, it is not sinusitis. I'm not saying that it's not debilitating. I'm not saying it doesn't decrease quality of life. It's just not sinusitis. We still need some way to treat those kids. I don't have an explanation for that. I'm just as baffled by these problems as you guys are. Yeah. So there are some kids, I think, who do grow through when they do sort of go through puberty, that sort of runniness or chronic mucus production does taper off. And then I think there are a group of kids who it actually persists. In the adult literature, there is some feeling that those kids may be the kids who are precursors to adult CRS, sort of like maybe early onset adult CRS. So they start sort of as snotty-nosed kids, then they end up with sort of a really persistent chronic inflammatory rhinitis, and then they sort of go down the pathway of chronic inflammatory paranasal sinus disease.
How about middle ear fusion? What do you think about that in relationship to sinusitis in kids?
The question was how are ear
pathology? Yes, middle ear.
Yeah, I think it's really common. It's really common. I mean, the middle ear is just another sinus. The mastoid is just another sinus, right? And so they have this chronic inflammatory condition happening in their paranasal sinuses. They have it in the mastoid too. And so I think a lot of these kids end up needing ear tubes. They probably, by the time they get to me, because my referral base is from pediatric otolaryngology, they usually have or have had ear tubes. So I'm not necessarily managing that, but I think it's really common.
Can I ask you to take a look at the chat lines? There's quite a few questions for you.
Sure. So the first one I see is, can we replace CT scans with MRI sinuses? Second question, what happens to these children when they become adults, which I sort of just talked about. Will their sinus disease get better or worse or the same? Okay, so the answer to that is MRI is okay, right? Absolutely, you can follow kids with MRI. MRI is, at least here in the US, MRI is expensive, and it is difficult for children to sit in the MRI machine. They have to, depending on the age of the child, the child will have to be sedated. A CT scan is quicker and less expensive, but a CT scan is radiation. So I try to reserve my imaging really to the last minute when I think like, okay, this kid either need surgery, or I just can't understand I can't give these parents a proper recommendation without having some sort of imaging to qualify the child. You can do MRIs. The kids come with MRIs a lot. It is helpful, but in terms of surgery or surgical planning, I still believe you need the CAT scan. So I certainly don't do serial CAT scans. You don't do that. I would do one. I'm looking to do one total if I can. What happens to these kids as adults? It's a great question. So I think it really depends on the age of onset. I think kids who are under 12, they usually, I shouldn't say usually, but they often have some sort of underlying condition that's driving the CRS, whether it's an immunologic deficiency or some other medical issue. Kids over 12, they may be the ones who are more leaning towards the chronic inflammatory adult style CRS, and they may go on to have sort of lifelong problems with CRS. So I don't think that you can predict it at this point. What is your recommendation about the saccharin test for nasociliary motility disorder? Well, I think you can try it. It's definitely, the transit time of the nasal cavity is documented. So, it's certainly something to try. Ultimately though, I think that people are going to use electron microscopy to really diagnose a ciliary dysfunction, but it sort of leads you onto the right track. So I think you can try it. Can we do full house FES in children? Yes, you can do full house FES in children, but remember that children don't have fully developed paranasal sinuses, right, until they're about 17 or even 18 years old. So one thing that when I counsel a parent when I'm going to operate on a child is I actually always tell them, listen, I'm trying to get your kid to feel better. I'm not curing your child of their sinus disease. There is no cure for it. It is a chronic condition. But I want them to feel better, knowing that the child will grow and their sinuses are going to develop further, and there may be more to do in the future. So one way I think about this is trying to postpone surgery as long as possible to get the kid older, right, and more developed. And the other thing is the counseling. So to tell the patient that, tell the parent that if I operate today on your 10-year-old, when your child is 16 or 17, and if they still have chronic sinusitis, they may still have cells present or new cells that I need to go in there and I need to work on. So the long and short of it is, yes, you can do full house FES, but you have to understand that they are still developing. Is there any role of eosinophil count in nasal mucosa biopsy? Yeah, so this is a great question. And hard to answer. I think there is a role for eosinophil count. I know that here in our institution, it's hard to get an eosinophil count. These things are sort of sent to the lab, and as cursory pathologic examination is done and move on. Other institutions I know are able to really have a specific checklist that they go over with pathology, that pathology goes over, and eosinophil count per high power field is in that. So I think it can be helpful, because if you have a hypereosinophilic syndrome, that's how you have to diagnose it, by eosinophil count. Is pneumococcal vaccine preventative? So this is a great question. So the answer to that is it's unclear, right? But we are seeing a significant amount of specific antibody deficiency in the kids who have chronic sinusitis. So I don't know if it's preventative. I do boost the kids because they're deficient, and I want to see if they ultimately respond, because if they don't respond, then I'm worried about either CVID or going on to develop CVID. So it's unclear, but if it's preventative or not. What about the combination of LTRA and intranasal steroid in the first place for CRS with adenoid hypertrophy in children? Yeah, so you certainly can. I think leukotriene inhibitors or receptor blockers are very. You can certainly try those in adults with intranasal steroid. In kids with intranasal steroids. I often have kids on Singulair, or that's the brand name, on Montelukast and a nasal steroid. But I guess the kids that I'm talking about are the kids who don't respond to that. But yeah, you're going to have a population of children who are going to respond to that. So you should try that before you go on to anything like surgical. Related to the COVID-19, what do we do for treating patients with CRS? Well, I think that's a tricky question, and I'll tell you why. Because here in the U.S., if the patient has active SARS-CoV-2 infection, I would treat that patient medically. Now, if you're talking about complicated acute or like acute on chronic or complicated like or a subperiosteal abscess, intracranial abscess, or even meningitis, I mean, obviously that's got to be treated. So it's treated surgically. So typically, so in those cases, we would use appropriate personal protective equipment, and we would treat that patient. So in specific to COVID-19, I would just treat them I'm treating them the same way I treat all CRS patients. Any role for Montelukast? We just discussed this. I do think there's a role. Which is the minimal age to perform adenoidectomy? I mean, I don't think there's any specific minimal age. I mean, your pediatric otolaryngologist will tell you 6 months, I think, is like kind of the age they will start, considering operating on a child. Most kids, I think they wait till, if your kid is under 1 and even under 2, it's really hard to determine if that kid really has CRS. So I would most likely start seeing them maybe in terms of kids who are getting adenoidectomy for a nasal complaint, between 2, 3, even 4. But that's typically done by a pediatric otolaryngologist prior to my examining them. When you request CT sinus in children after adenoidectomy or simple arc, so I never get simple plain films of the sinuses. I feel that's excess radiation and it's not going to give a significant amount of information. Plain films do have a lot of radiation, and your CT scans now, they're honed down to such a degree that they're not so different. And so I just feel like you're going to get so much more information from a CAT scan that I typically go to a CAT scan if I need it. Like I said, most of these kids who are going to get a CAT scan, they've already had adenoidectomy and things like that. So I guess my advice would be after adenoidectomy. But obviously your clinical judgment always has to play in there. But like I said, I always try to resist CT scanning until the last possible moment. How do I deal with orbital complications? So orbital complications, I assume what you're referring to is like subperiosteal abscess or orbital abscess. Kids under 6, we try to treat them here with antibiotics and steroids. They has a high rate of improvement with antibiotics and steroids without needing to have surgical drainage. But if they aren't improving, or if they start worsening, then we do an ethmoidectomy and usually could pretty easily decompress the orbit from the pus. You don't even usually need to take any lamina down because there's already typically a dehiscence in the lamina. So you can just sort of softly palpate the eye and the pus usually washes out of the ethmoids. And that's, frankly, in my experience, has been really all I needed to do. At what age do I start prescribing nasal steroids, and which one? So in the US, mometasone is the nasal steroid that is approved for children. So I try to prescribe mometasone. Here, insurance can play a role in that. Sometimes mometasone won't be covered, and then we'll use fluticasone. Like I said, the kids I start seeing the kids are with sinonasal symptoms can be like around 2 or 3. And I think at around 2 or 3, you can start giving 1 spray in each side and seeing if that helps. Is allowance delete the FES only for SRCS until 10 years?
How about oral steroids? How about giving oral steroids?
Yeah, so, I
part of medical management.
Right. I think there's risk giving oral steroids to kids, and, they're going through bone growth. And so I'm not opposed to it. I'm much more hesitant than I am in adults. But when I talk to pediatricians, they usually don't have a problem with giving a kid a steroid burst. Kids get steroids for asthma, obviously. But we do have to think about their total steroid intake. If you're giving them a nasal steroid, they're an asthmatic, they're taking an inhaled steroid, and then you're giving them a burst of oral steroids, that can ultimately add up. I do it. I just, I'm pretty reserved with it.
And there's another question from Dr. Ritchie about low-dose macrolides as an anti-inflammatory for children.
Yeah, so low-dose, there's definitely low-dose macrolides can be used as an anti-inflammatory. There's data in the adult literature that shows that to use it People have done it as much as 3 months or even consistently a couple times a week, indefinitely. In my adult population, I use macrolides a lot for their anti-inflammatory properties in my chronic sinus patients. In my kids, I do use them, but I have very few kids that I have chronically on them. I can only think of one off the top of my head, but it does help in this one child. He is on he has a macrolide use, and he also has an immunodeficiency. So it's really been helpful for that one child. But I think it's the immunodeficiency in this child that's driving the chronic inflammatory disease, and using the macrolide is helping him. So yes, it is done.
Well, thank you very much, Aaron. It was a great talk. I think we all benefited from it. We really appreciated you taking the time with us this morning. Thank you.
You're very welcome. It was my pleasure. I'm really happy to do it.
Great. So I'm going to share with you what's coming in the next week with our slide rotation, and we'll see you hopefully tomorrow with Dr. Vivi Young. She's going to talk about management of complication of voice and airway surgery. Thank you all, and have a nice evening.
Bye-bye. Thanks.
Bye.